Good evening, everyone. A very warm welcome to you all for this today's webinar, the next in the series of managing and RH negative pregnancy. This is a webinar by Perinatology Committee FOXI along with Cananor OBGY Society and organized and supported by TOG Science Integra. Today we have an array of star-studded faculty with us. And before we start with the webinar, I would like to thank our President FOXI, Dr. Alpesh Gandhi, for this opportunity. We would also like to thank ICOG for granting us one ICOG credit point. Special thanks to Dr. Meg Madam and Dr. Parag Biniwale. And I would like to urge each and every one of you to be a part of ICOG, which is doing excellent work. It is an academic partner of FOXI. And if you have already not taken your fellowship, I would really request you to go ahead and get the fellowship of ICOG, that is FICOG, and be a part of ICOG. So for this today's webinar, we are going to start with one talk by Dr. Saijus, the very dynamic president of Cananor Society, followed by a panel discussion on management of RH negative pregnancy. And before we start, I would like to welcome our Vice President, Dr. Ramani Devi. Ma'am is the chief guest of today's program, today's webinar. And thank you, ma'am, for being here today. The panelists which we have today, star-studded, is Dr. Parikshit Tang. He is the Joint Treasurer of FOXI, Dr. Uma Ram, Dr. Tarakeshwari, Dr. Manikandan, Dr. Ajit. We have highly esteemed chairpersons who are presidents of different societies. That is Dr. N. Sumati, Dr. E. S. Usha, Dr. Indira B, Dr. Madhavi, Dr. Kasturi, Pramila. And now I would request Dr. Saijus to make a formal introduction of a chief guest and request ma'am to say a few words.
Yeah. Thanks a lot, Vaishali Madam, for this wonderful opportunity. It's a privilege that Cananor Obstetric and Gynecological Society has got the privilege to collaborate with such a committee like Perinatology Committee under a very dynamic chairpersonship of a person like you. It's such a privilege. And adding more happiness to this academic get-together is the presence of our chief guest, a person who hardly requires any introduction for the amount of dynamism that she has showed in terms of her work related to women empowerment, the kind of social commitment that she has, and never to forget the work that she has done for the National Organization of Gynecologists named FOXI. It's a privilege to welcome Dr. T. Ramani Devi Madam, and extremely happy to have the privilege of introducing her. She's the Managing Director of Ramakrishna Medical Center LLP and Janani Trichy Fertility Center, a person with a wonderful academic background to come up with almost 10 gold medals during the undergraduate and postgraduate periods. She is winner of the Professor C.S. Dawn Prize in 2006, 7 and 2013. She was a very dynamic chairperson of the Endometriosis Committee of FOXI from 2014 to 16. She was the IMA National Best Secretary Award was won by her in 2006. The Woman of the Year Award by Bharati Dasan University in 2013. The Woman Achiever Award by Citizens of Trichy in 2015. Dr. APJ Abdul Kalam Award in 2016. The Dr. Navamani Bose and Dr. Rameshwari Nallusami Oration was delivered by her. She was the recipient of Dr. Datta's Award for the Best FOXI Focus in 2016, a recipient of Dr. Mehrudara Hansotia Award for the Best Committee in 2016, has presented papers in various national and international conferences, authored books, co-authored 5 publications, an investigator in the POISE trial published in the Lancet, an editor of FOXI GCPR on endometriosis in 2017. And that is one topic which comes to your mind whenever you hear about Ramani Devi Madam. I think it equates to endometriosis, and the way she has probably helped us to solve the dilemma of demystifying this relatively unknown disease has been probably, according to me, one of her major contributions to this field of academic teaching for gynecologists. She was awarded much deservedly the SN Pandit and Shailaja Pandit Award for Women Empowerment in 2017, was elected as the ICOG Governing Council member in 2018 to 20. is a PhD scholar. And I think much more than this achievements, I think what we should always understand when we talk to and interact with Madam is that she is a learner forever. And that helps her to teach us all very well, even today. So whenever there is a topic given to her, she makes sure that even today she does her preparations very well. That's why we have the fortune of getting the most updated information when you get an opportunity to listen to Ramani Devi Madam. And most importantly, she is the National Vice President of FOXI of 2020 and the International Advisory Board member of Endometriosis Society of Bangladesh. So with a lot of love and affection, it's my privilege to invite Dr. T. Ramani Devi Madam, the National Vice President of FOXI 2020, to inaugurate this webinar conducted by the Perinatology Committee of FOXI under Dr. Vaishali Chavan in collaboration with Cananur Obstetric and Gynecological Society. Over to you, Madam.
Thank you, Dr. Shaijas, for the nice words spoken. I'm extremely happy to be the chief guest for your Cananur Society program. I think this program is going to be a superb one because already Vaishali had done a previous same topic, RH incompatibility, in which I was one of the panelists. That was an extremely well conducted program. And today, added to that, we have galaxy of faculties like Umaram, Dr. Tarakeshwari, Dr. Parishit Tank, Dr. Manikandan, and Dr. Ajit. And I think it will be a sort of knowledge gathering for anybody who is logging into this particular program. And I also welcome all the chairpersons, Dr. Sumati, Dr. Usha, Dr. Indra, Dr. Madhavi, and Dr. Kasturi for this August meeting. So I don't want to waste much of time, and all of us know that RH incompatible pregnancy is a very, very important topic. Though around 8 to 10% of the couple have RH incompatibility, not everybody suffers from this particular disease. There are so many reasons behind that. But still, if the patient gets an RH incompatible pregnancy, then coming out of it and planning delivery and how the advances that we have had it now in the form of early diagnosis by the use of ultrasound. I think Manikandan is there to share his view, and obstetric management part of it, Umaram, Ajit sir and Tarakeshwari will be able to give you an excellent review. Added to that, and we have a very good neonatology team where we can bring about the child and the mother with a happy end. So I would like to share my own assistant. She had a threatened abortion. She never revealed to me that she was RH incompatible. And finally, at 32 weeks of gestation, we have to have the baby was highly isoimmunized, and we had to give her an intrauterine transfusion. And finally, we had to deliver her, and both the mother and the baby are fine. So even the educated people, they fail to think, our own profession, they fail to think it. So I think this should be a very, very important topic. And I wish the program a grand success. Vaishali, hats off to you, for I have been watching all your programs extremely well. And the more important thing is, I appreciate your idea of focusing upon ICOG in this platform, because it is the academic wing of FOXI, where more and more of our members should be joined together. I'm happy this year ICOG credit points has been given extremely well. It has been distributed by Meg Madam and Parag sir, and Meg Madam is doing extremely a very nice programs. And we had the opportunity of myself and Sampath, we just released one endometriosis book as well as one newsletter. I think it is giving a platform for all the ICOG members to update our knowledge and exhibit our talents. And I congratulate once again Vaishali and Saijas and all the moderators and the panelists for this August program. And I also welcome the delegates for this. Thank you for the opportunity given, Saijas.
Thank you, Ramani ma'am, for your very kind words and for your guidance. And it is indeed a blessing to receive your best wishes for this webinar and for all the work that we've been doing and all the work that my committee, Perinatology Committee, is doing. And yes, we did have a webinar with ma'am's presence, and the way she guided us brilliantly on this topic was like too wonderful. So thank you, ma'am, for being with us today. for coming and guiding us today. So now moving on to the first talk of today's webinar. This is by Dr. Shaijus, and he is going to be speaking on the role of anti-immunoglobulin in management of Rh-negative pregnancy. So as you know, he is the president of Kannanur OBGY Society, Kerala. He is chairperson, Research Committee, Kerala Foundation of OBGY. He is fertility specialist at ARMC IVF Fertility Center, Kannur. He is a gynec-laparoscopic surgeon and he has received many awards. Foxy has Talent Award in 2017, Foxy International Traveling Fellowship in 2019, Foxy Superstar Award, that was last year. He has also delivered Dr. Kamini Rao Oration in 2018 and Foxy Future Award in 2017. So to chair Dr. Saiju's talk, I would request all the chairpersons to be present. That is Dr. N. Sumati, President Madurai Society, Dr. E. S. Usha, President Erode Society, Dr. Indira B., President Kurnul Society, Dr. Madhavi G. B., President Karimnagar Society, and Dr. Kasturi Pramila, President Warangal Society. Welcome, please. Yes, Dr. Sanchez.
Yeah. Am I audible?
Yes, audible.
Yeah. Thanks a lot, Vaishali Madam, once again for this collaboration, and it's a wonderful opportunity. It's a privilege, in fact, to be amongst such elite panelists and such a wonderful dynamic chairperson in you. It's a privilege for the Kannur Society also to be collaborated in this effort. So without any more intro, let me get on with my lecture on role of anti-immunoglobulins in managing Rh-negative pregnancies. We have talked about it for long, but we continue to debate and discuss a lot about it because it's a very relevant topic. And I promise that nothing related to the management of this pregnancy would be negative other than the maternal blood group, because we are hoping to bring out the most positive outcome for the mother as well as the baby in managing an Rh-negative pregnancy. If you look at the source of anti-D, it is primarily being manufactured from pooled plasma from those with high titers of IgG antibodies to D-positive erythrocytes. For a long time, it used to be obtained primarily from allo-immunized women. Then across the world, because of various interventions, the incidence of allo-immunization started dropping down. Then we started looking at male donors who undergo repeated injections of D-positive red cells and develop high titers of antibodies, and they were used. Finally, as most other human resources, there was scarcity, and that has primarily led to the search of a synthetic anti-D immunoglobulin. Future holds good in most scenarios, just like this shampoo vending machine, which will do the job when you're doing your brushing. And future promises some good things for anti-D immunoglobulins too. We're looking about a synthetic product which can be available in much better amounts without any scarcity, as well as a synthetic product which would eliminate the risk of pathogen transmission and adverse reactions due to impurities in plasma. To have a closer look at the pharmacology and pharmacokinetics, a 300 microgram dose of anti-D is the most common used one and equates to 1,500 international units. And this contains sufficient anti-D to suppress the immune response, which is caused by 15 ml of D-positive red cells or 30 ml of D-positive whole blood. This is something which you have learned even from our undergraduate days. If you look at the smaller dose, which is 50, that would contain 250 international units. It's sufficient to suppress immune response to 2.5 ml of D-positive red cells or 5 ml of fetal whole blood. The mean half-life of this product is somewhere close to 24 days. On an average, you can say 3 weeks. But in a small proportion of patients, as far as studies results are concerned, with highly sensitive assays, it has been noted even up to 95 days after a routine antepartum injection. And sometimes, occasionally, as long as 180 days, it has been present in blood. If you look at the mechanism of action, something you would straight away remember is the masking action, which is what we learned during our undergraduate days. But remember, this masking of antigenic sites, which is otherwise called the epitope masking, is no longer, according to the present evidence, is thought to be the primary mechanism by which anti-D works. The reason being that a significant number of D antigen sites on fetal RBCs in maternal circulation are not bound by the passive anti-D immunoglobulins that we are actually giving. So what are the mechanisms that actually work? One is that those fetal red cells which are coated by the anti-D that you're giving are rapidly cleared by a macrophage-mediated process, and that works well. The other mechanism being the downregulation of the antigen-specific B cells before they launch an immune response. If you look at the efficacy, I want you to remember 3 percentages: 16%, 1 to 2%, and 0.1 to 0.3%. 16% is the risk of a D negative woman becoming LO immunized after 2 deliveries of a D positive ABO compatible infant. If you give a postpartum dose of anti-D alone, the risk reduces to 1 to 2%. If you give an antepartum plus a postpartum dose, the risk reduces further to 0.1 to 0.3%. So 3 numbers to be remembered: 16, 1 to 2, and 0.1 to 0.3, which will tell you how good this product is. Now, also remember that we have not been completely able to eliminate D-LO immunization, primarily because of the failure to administer anti-D in accordance with the published guidelines. Also because of the fact that there's been some unsuspected fetal-maternal bleed early in gestation before the administration of 3rd trimester prophylaxis that happens at 28 or 34, depending on what recommendation or protocol you're following. Some fetal-maternal bleed can happen much before your 3rd trimester prophylaxis. That also has been a reason why we haven't been able to completely eliminate this particular issue. If you want to compare evidence from most studies, you look at the relative risk. If you compare a postpartum dose alone with no treatment, then it reduced the incidence of D-LO immunization with a relative risk of 0.12. An antepartum plus postpartum versus only a postpartum, it lowered the risk of LO immunization with a relative risk of around 0.42. People love to take risk, isn't it? Sometimes they know very well how risky the entire procedure is. When anti-D came into being, people are also concerned about certain risks which could happen to the mother and the baby because of this product. And the worries were whether this anti-D could increase the risk of fetal anemia, whether it could lead to enhancement of the maternal primary immune response to D positive red cells, whether it would increase the incidence of adverse obstetric outcomes, whether it could reduce maternal response to postpartum immunization, especially immunizations like rubella, whether short or long-term harm to the fetal immune system can happen because of this anti-D. But trust me, as far as the current evidence goes, there's nothing to suggest that the maternal administration of anti-D has any significant risk to the mother or the baby. If you look at infection and allergic reactions to this product, plasma units for making anti-D are generally tested for antibodies to hepatitis B, hepatitis C, HIV, and parvovirus. Remember 2 processes. One is called called ethanol fractionation, and the other called a viral clearance ultrafiltration. Both these 2 processes are relatively pretty good in removing viral particles, especially hepatitis A, hepatitis C, parvovirus, B12, and HIV. And if you have an anti-D product which is being prepared by this particular mechanism of ethanol fractionation followed by a viral clearance ultrafiltration, for example, the ones in the market are Hyper-Ro, Rogam, and Bero. Those are the ones which need to be administered only intramuscularly because they are still impure and contain some amounts of IgA and other plasma proteins. Now, if you have a product which is being prepared by ion exchange chromatography, which is more purer, for example, like Rofelac and Winro, which are in markets, they are much more purer and can be given either intravenously or intramuscularly. So the general approach would be that all D-negative pregnant women should undergo an antibody screen, I mean to say an indirect Coombs test, at the first prenatal visit of each pregnancy. This blood test, as you all know, is accurate and relatively inexpensive. If antibodies are identified, that means if she is ICT positive, she is counseled about continuing the pregnancy, utilizing the interventions for predicting the risk of hemolytic disease of the fetus and the newborn. HDFN is what we call it. And those interventions to diagnose and treat severe fetal anemia. We would be discussing about all these in detail from the fetal medicine consultant itself in the coming panel. Screen positive women, as you already know, should not receive anti-D. Remember that it is not effective once LO immunization to the D antigen has occurred. And as some thought, Whether it could prevent a rise in maternal titer? No, it does not prevent a rise in maternal titer once yellow immunization has already set in. Fine. Now, who are the candidates for anti-D immunoglobulin? Now, D negative women with a negative ICT and who are carrying a fetus that is or may be D positive are the candidates for anti-D. Generally, the first dose is an antepartum prophylaxis. Generally comes at 28 weeks of gestation. Second dose would be after delivery, after checking for the newborn's blood group and found to be D positive. Additional doses are when an antepartum event has occurred, which increases the risk of fetal-maternal bleeding. Remember that D negative women who are carrying a D negative fetus does not benefit from anti-D. Now, people thought whether having a closer look at the father can help. I'm talking about paternal D typing. If the biological father of the fetus is known with certainty to be D negative, then the antenatal anti-D doses may be omitted. But remember that assurance of paternity always has to be documented in the medical record, because there is a meta-analysis which has showed that there were issues related to paternity in almost 3% of management of Rh incompatible pregnancies. So always put it on record. Now comes the use of NIPT, looking at cell-free fetal DNA in the maternal plasma for looking at the baby's blood group intrauterine. Fine. Now, this entire area is controversial. Now, in those countries where it is practiced routinely and in those situations where it is clinically indicated, if you do a cell-free DNA we are looking at fetal elements in maternal plasma, and the results suggest that the baby is male and D negative, then an antenatal anti-D can be omitted. Okay. Now, however, if you find that the results tell us that the fetus is female and D negative, there is a possibility that the result is reflecting the maternal status rather than the sex of the baby. So, if you look at various countries, you would find that England and Australia are areas where a fetal RHD genotyping by the cell-free fetal DNA technique has been found to be a cost-effective option. So they allow it. When they looked at a cost analysis in 2018 in US, they found that it doesn't appear to be a cost-effective option. In countries like these, Denmark, Netherlands, Sweden, England, France, and Finland, fetal RHD determination is performed routinely in D negative women. What is the advantage? Over 1/3 of Rh negative women can avoid taking an antenatal anti-D if they come to know that their baby is also negative. That is the advantage of using this technique. Okay. Now, what is the disadvantage? Remember that this selective approach of finding out the baby's blood group and then deciding whether to give the antenatal anti-D or not has the potential to increase the number of cases of D yellow immunization, because there is a possibility of a false negative test with cell-free DNA. Prophylaxis at 28 weeks of gestation. Even if you have done an ICT at the first prenatal visit, it is always better to repeat an ICT at 28 weeks, because there is a possibility that an innocuous episode has happened which has gone unnoticed, which could have caused fetal-maternal bleeding from the first visit to the time of antepartum prophylaxis. So repeat antibody screening with an ICT at 28 weeks will detect the rare women who has become immunized in the interval since the first screen. A single dose of 300 microgram of anti-D is administered. In United Kingdom and Canada, they follow a 2-dose regime. 100 to 120 micrograms of anti-D are given at 28 and 34 weeks of gestation. Now, there is a network meta-analysis which has found that a 2-dose 28 and 34-week regimen of 300 micrograms each was more effective than a single dose of 300 at 28 for reducing the incidence of yellow immunization. Now, who requires additional cover-up? This is something which most of us do know. One is regarding a spontaneous or induced abortion. Remember that D antigen is detectable very early on embryonic red cells, as early as 38 days after conception. If you want to talk in terms of weeks, it is 7 plus 3 weeks of gestation. So even early abortions could come into the picture as far as giving a cover-up is concerned. Some groups decide that they will not recommend a prophylactic anti-D if it has been a complete spontaneous miscarriage before 12 weeks of gestation and they are sure that the uterus has not been instrumented. Fine. That means a complete spontaneous miscarriage with no instrumentation before 12 weeks, you may decide not to give an anti-D. Now, if we compare the rates of spontaneous versus induced, obviously the rates of and the risk of allo immunization are more, 1.5 to 2% for spontaneous abortions, 4 to 5% for induced abortions. Invasive prenatal diagnostic or therapeutic procedures, chorionic villus sampling, amniocentesis, fetal blood sampling, fetoscopy, and multifetal reduction. We have a specialist in this field who will be talking more about these in the coming panel. Blunt abdominal trauma and external cephalic version. There are possibilities of fetal-maternal bleed happening, so you require an additional cover-up. Ectopic pregnancy, there were a lot of hot debates whether ectopic pregnancy can actually lead to fetal-maternal bleed, but it has been documented and they have found that mechanism may be either of the two. Either it could be transplacental or it may result from absorption of fetal blood from the maternal peritoneum. Threatened abortions, yes. Anti-immunoglobulins are administered to women with significant clinical bleeding and not just spotting. Okay, this is some reasonable good evidence which would tell you that almost 20 to 40% of pregnant women would experience some kind of spotting in early pregnancy. And allo immunization is very, very rare in such women. And hence, you can give anti-D only in those cases where there is a significant clinical bleeding. And if you want, you can avoid when there is only spotting. An incidental finding of a subchorionic hematoma in an otherwise asymptomatic patient is, for the time being, not an indication for an antepartum prophylaxis. Fetal death in the second or third trimester can also be because of an allo immunizing event, especially the ones that are caused by a massive fetal-maternal bleed or an occult abruption. Antepartum bleeding in the second and third trimester, yes, we need to give. Fetal-maternal bleed is much more in placental abruption, as you already know, than when compared to placenta previa. Hydatidiffer mold, a complete mold, generally there are no fetal red cells, but in a partial mold, there are fetal red cells. So a prophylaxis after evacuation is indicated. More importantly, always give anti-D. Benefit of doubt by giving anti-D when you are unable to determine the type of pregnancy, especially those patients who come to you after a bleeding episode. And by the time they have reached the hospital, almost everything has got expelled. And you do not have products to actually look at and decide whether it has been a normal pregnancy or an abnormal pregnancy. So whenever in doubt, give off anti-D is the dictum. What about the doses before I conclude? First trimester, generally the amount of fetal-maternal bleed is very less. The volume is very less. So a 50 microgram dose would be good enough. Remember that if you do not have a 50 microgram dosage with you, there is absolutely no harm in giving the standard 300 microgram dose, which is more readily available. Second and third trimesters and postpartum, the standard 300 microgram dose. Whenever an anti-D immunoglobulin is indicated after 20 weeks of gestation, it is always better to quantify the fetal-maternal bleed. Then what to do with those women who have repeated episodes of bleeding, recurrent bleeding, when you have already given anti-D once, what to do next? One recommendation is to monitor maternal ICT every 3 weeks in women with recurrent antepartum bleeding and who has already received a prophylactic dose. That means for the first episode of bleeding, you have already given an anti-D. And how will you decide whether she requires a second dose when she has been bleeding in multiple episodes recurrently? One way is to look at ICT. Now, if you look at ICT after 3 weeks and the result comes positive, that actually indicates that the anti-D immunoglobulin from the previous dose that you have given is still there. So no additional treatment is necessary. Now, if the result is negative, then the woman may not actually be protected. In these cases, it's always best to test and evaluate the volume of fetal red cells which have entered the maternal circulation, and that blood sample is obtained before the repeat dose of 300 micrograms of anti-D is administered. How do you test a fetal-maternal bleed? Remember that the incidence of a larger fetal-maternal bleed, that is anything more than 20 to 30 ml, incidence is approximately 1 in 200 to 300 deliveries. And because that is the limit beyond which your 300 microgram dose will not actually cover. A Rosette test is generally suggested for the initial screen. It is a qualitative test, yet a very sensitive test for fetal-maternal bleeding. Now, a standard dose of anti-D is given to patients who has a negative Rosette test. A negative Rosette test would mean that the amount of fetal-maternal bleed is small, less than 2 ml, or only less than 0.04% of fetal red cells are available in the maternal blood. Fine. Now, when the Rosette test, if in case it is positive, you need to go ahead and do a little bit more. You can either do a Clahor-Betke or a flow cytometry is recommended to determine the percentage of fetal red cells in the maternal circulation. So a quick recap before I finish. All D-negative pregnant women should undergo an antibody screen at the first prenatal visit. If the initial screen is negative, a repeat screen at 28 weeks of gestation is always better prior to administration of anti-D to cover up and find out whether any episode of fetal-maternal bleeding has happened in between. For women who are D negative and whose fetus is or may be D positive, routine administration of anti-D immunoglobulin early in third trimester is a very effective method with a grade 1A evidence. Optimum dose regime is 300 micrograms at 28 weeks of gestation for antepartum prophylaxis. Administration of anti-D is needed whenever there is an increased risk of fetal-maternal bleeding amongst all those scenarios that I've just now mentioned, and that comes with a grade 1B evidence. Testing for quantifying fetal-maternal bleed is better done for events that can cause fetal-maternal bleed beyond 20 weeks of gestation. Repeat doses for those with repeated bleeding episodes better be decided by results of ICT, which is done after 3 weeks of the first dose. Administration of anti-D within 72 hours of delivery of a D positive infant is the one that is recommended, that comes with grade 1A evidence. And if you have missed out on the 72-hour interval, give it as soon as you have remembered it, because partial protection is afforded even within 13 days of birth, and maybe an effect is still there as late as 28 days after birth. Thank you so much, and I humbly request your support for my elections, upcoming elections, as a chairperson of the Midlife Management Committee of FOXY. So requesting your support, and hope you enjoyed the lecture. Thank you so much.
Thank you, Dr. Saijus. That was a wonderful lecture. You have explained everything with such clarity, and we wish you all the very best in your elections and your further endeavors. I request the chairpersons to make few comments.
Well, Saijus, your talk was so nice. Any idea about this intramuscular or intravenous immunoglobulin? Any specific differences there?
They have looked at a reasonable amount of evidences, and they have found that efficacy-wise, there is basically no difference. Depending on the technique used for preparing, that means depending on which preparation of anti-D you're using, you will have to decide whether you can give an intravenous route, or is it otherwise the always preferred intramuscular route for the less purer preparations. Otherwise, efficacy-wise, no difference, madam, as far as the present evidence goes.
Hello. In multiple pregnancy and Rh negative women, is there any change in the dosage? Hello.
You'll have to unmute yourself.
This is.
You're on mute, Dr. Saijus. You're on mute. Unmute yourself. Can you repeat your question, ma'am?
Yes, in multiple pregnancies, is there any dose is the same, or we have to give in an extra dose?
Yeah, since I think he is still on mute, whether it is singleton or multiple pregnancy, the recommended dose remains the same. Whatever is recommended for antenatal prophylaxis, post-delivery prophylaxis, the recommended dose remains the same.
Okay, thank you.
Any other comment from our expert chairpersons? So I would like to thank each one of our chairpersons, and thank you for being with us, and thank you, Dr. Saijus, for this wonderful lecture. So can we move ahead with the panel discussion? I request Dr. Saijus to take over now.
Can you hear me now?
Yeah, we can hear you now. So can we move on to the panel discussion now?
Can we have the CVs, please?
Okay, just winter respond.
Yeah. I hope I'm audible now.
Yes.
Am I audible now?
You're audible.
Yes, you are. Yes.
Thank you. Yeah. We have a wonderful panel, which is. Can you mute all? I think there's some disturbance. We have a wonderful panel that is lined up regarding management of Rh negative pregnancies, and it's such a privilege that we have a elite group of panelists along with a wonderful dynamic chairperson. To moderate the panel, it's my privilege to welcome Dr. Vaishali Chavan, whom, as you already realized by now, is the chairperson of the Perinatalology Committee of FOXI. She's the director of Sahyadri Super Specialty Hospitals at Hadapsar in Pune and works at Sanvi Clinic. She's a postgraduate teacher. She was the executive vice president of Pune OBGYN Society from 2019 to 2020. Many national and international publications to her name. Various awards received, including the Punya Bhushan Award in 2017, Samaj Bhushan Award, Vaidya Gaurav Puraskar Award in 2017, Lokmat Award in 2017, Inspiring Gynecologist of West India Award by Economic Times, and the Times of India Award in 2019. So such a privilege to have such a dynamic person as the moderator. We have some elite panelists in the fray. None other than Dr. Parikshit Tank, who is, as you all know, is the present joint treasurer of FOXI. He's a consultant at Ashwini Maternity and Surgical Hospital and Center for Endoscopy and Assisted Reproduction at Mumbai. He's also the consultant at Jupiter Hospital at Thane. She's was the chairperson of Safe Motherhood Committee of FOXI from 2014 to 17 and is the managing committee member of Mumbai, illustrious Mumbai OB-GYN Society. A lot of awards and publications to his name. Dr. K. Bhaskar Rao Gold Medal for first place at DNB. Dr. Kamini Rao Yuva FOXI Orator in 2011. Over 100 peer-reviewed publications in index journals. That's a big number. CME publications, textbooks. Co-authored almost 4 books in OB-GYN and on the editorial board of 4 index journals. Such a privilege to have you, Parikshit sir, in this panel. None other than Dr. Umaram, who is a director and consultant OB-GYN at Sitapati Clinic and Hospital at Chennai. She is the chairperson of the Southern Zone AICC RCOG. She's an examiner of Part 3 MRCOG, a coordinator for Part 2 and Part 3 MRCOG courses in Chennai, 2003 to 2018, has contributed chapters, edited books, publications, Young Gynecologist Award 2007, AOFOG IDF Blue Ring Woman Achiever Award by Rotary International in 2015. Areas of interest include fetal growth, multiple pregnancy and fetoscopy, GDM, health awareness in women with some lovely hobbies. It's a privilege to have such a dynamic and ever smiling person in Umaram Madam as the panelist for today. Also a privilege to have Dr. Tarakeshri Madam, the director and head of the obstetric medicine unit at Fernandez Hospital in Hyderabad, a state-of-the-art institute which provides protocol-based management, who sets up examples for the entire nation to follow. A special interest are medical disorders complicating pregnancy, recurrent pregnancy loss, and high-risk pregnancy. Madam doesn't believe in writing too much in her CV slide because of the type of personality she is. She's such a down-to-earth person. And I know the panel will really bring out the quality of the kind of teacher and the academician that she is. Thank you so much, Madam, for being a part of this panel. Dr. K. Manikandan, my dear senior, my mentor, a person who has actually molded me from my postgraduate days in a lot of ways. And I do not generally have any hesitation in telling that. He's a present consultant at maternal fetal medicine in fetal clinic, something which he has started of his own, a concept which is generally running well around the area where he's practicing. He has postdoctoral fellowship in fetal medicine from under Dr. Suresh at Mediscan Systems, Chennai, a pioneer in this field. He was a former associate professor of obstetrics and gynecology at JIPMA, a research fellow in fetal medicine, King's College Hospital in UK. He's got special training under National Teachers Training Course for Teachers of Higher Education from JIPMA, a statistics and epidemiology training from Harvard, an online initiative of Harvard University, a principal investigator and DBT-funded fetal growth charts project. His research focuses primarily on pre-eclampsia prevention, and I know something which is very close to his heart. And the panel will bring out the best in him, I'm sure. Dr. Ajit, a real a senior, a loving senior, a very, very supportive person, a person who's always been there as I grew up in my career after I landed in Kannur. A pillar of support for the N number of obstetricians that practice here. We always say on a jovial sense that he is on call every day. That means whenever any other obstetrician is on call, sir is also on call, because the opinions and the best decisions are taken with his consensus. He is the professor and the head of the department of Government Medical College, Kannur in Kerala. At a point of time when COVID numbers started increasing, he had managed, along with his team, single-handedly the maximum number of COVID positive pregnancies in India. But later on, as cases started increasing elsewhere also, the picture changed. He was a past president of the Kannur ONG Society, the past vice president of Kerala Federation of Obstetricians and Gynecologists, and more importantly, he is the president-elect of Kerala Federation 2021-22. Past chairperson of the research committee of KFOG, has been the joint secretary of Kerala Federation and a coordinator of the confidential review of maternal near miss committee of KFOG. So such a privilege to have a dynamic moderator and very well informed academicians as panelists. So all the best for a wonderful panel discussion, and I'm sure the audience is going to be really, really benefited from this. Over to you, Dr. Vaishali.
Thank you, Dr. Cyrus, for a very elaborate and kind introduction. And like you said, we are indeed very fortunate to have a very elite panelist here who will be giving their expert opinion. So starting with the first question, without already we have heard Dr. Cyrus, so let us take more clinical oriented discussion. So which covers right from the history till the newer investigation, role of Doppler, intrauterine transfusion, up till exchange transfusion for the newborn. So right from the preventive till the therapeutic, everything we are going to cover, and more of clinical and more clear take-home messages for our listeners. Before we start, I would like to tell you we have crossed more than 500 audience. We are getting a lot of questions already, and I hope as the panel proceeds, the questions will get answered. So starting with the first question with Dr. Parikshit Tang. Parikshit, this is a clinical case scenario. This is a Gravida 2 Para 1 living one. 10 weeks pregnancy. Her blood group is B negative, and she has come for routine ANC registration to the OPD. So there are two parts to this question. First part is how would be your clinical approach regarding the history, detailed history, obstetric history, husband's blood group, and all these things. Is detailed obstetric history important, and how? And the second part of the question is when will you advise her to do ICT and at what frequency? Yes, over to you, Dr. Parikshit.
Thank you, Vaishali. My thanks to Shaijas for the invitation to be here, and it's a pleasure to participate in today's program. That's a good place to start when we are talking about RH isoimmunization. Let's begin with something that is fairly routine, which most gynecologists will see at some point in day-to-day practice. So this topic, just to kind of put it into perspective, India is going to have about 2.5 crore births every year, and approximately 12 to 15 lakhs are going to be to Rh negative mothers. So that's a sizable population that we are looking at, who will generally present as Vaishali described. It's a Rh negative woman who comes to the clinic at about, thankfully she's come early in the pregnancy at 10 weeks. Now, though, typically textbooks will talk about taking a detailed history and exploring what obstetric events have happened in the past, how many miscarriages, deliveries, if there were any Rh sensitizing events, whether she took transfusions, and whether she was given Rh prophylaxis during her previous pregnancy and postpartum. The aim of all this is really to find out if this woman is sensitized or she is not sensitized. So as far as question number one goes, I would not dwell too much into these aspects. even for that matter, whether what is the husband's blood group, etc. Simply because that might put her into an awkward position. So rather than that, I think it is important to do a test to know whether this woman is sensitized or not. And the simplest test that we can do is an indirect Coombs test or an ICT. So that should be done at the booking visit itself. So at 10, 12 weeks, when she's going for her routine blood investigations, including the first trimester screening dual marker test, at that time itself, it's worth getting the indirect Coombs test done. So that's what the initial approach is going to be. And then, based on whether it's a positive test or a negative one, then you take it further based on what is the risk to the fetus.
Yeah, yes, Parikshit. So we have started with the first clinical approach. When the patient walks into the OPD, what is important? Like you said, past obstetric history, you did mention. Why is it important? Because if there is a history in the past, during the past pregnancy, where there was an affected baby, then there is a likelihood that this pregnancy also, the fetus is likely to be affected. In fact, at a much earlier gestation than the last one. The importance of doing ICT, you have stressed so wonderfully, Dr. Parikshit. Yes, ICT has to be done immediately. And then if it is negative in a primigravida, you should repeat it every 4 to 6 weeks till 26 weeks of pregnancy, and then every 15 days. For a multigravida, the testing for ICT may be more frequent than this. Husband's blood group, like you said, Parikshit, it may be embarrassing to some women in some situations. But overall, husband's blood group and especially the zygosity, if he's positive, whether he's homozygous, heterozygous, is very important, because if husband is heterozygous, then there's a 50% chance that this baby may be 50% Rh negative. But the zygosity is, if it is homozygous, then 100% all these babies are going to be fetus are going to be 100% Rh negative. So moving on to the next question, this is for Dr. Tarkeshwari. Is she there? Yeah, I can see, madam. So now we have done ICT and now the ICT has come positive. So what are we really worried about? We are worried about the hemolytic diseases of the fetus, because depending upon the level of agglutination and the destruction of the fetal RBCs, the fetus is going to be affected. So can you, ma'am, just guide us about and enumerate the hemolytic diseases of the fetus and the newborn?
Yeah, thank you, Vaishali and Saijas, and thank to all the panelists and the chairpersons. If the ICT is positive, we look at the Rh isoimmunized pregnancy and the effects on the fetus. So hydrops fetalis is one which we look at. The fetal anemia is what we are looking at, and then I refer to the fetal medicine specialist who look at the middle cerebral artery, PSV. And if the undetected, undiagnosed, you have a baby born with a, previously we used to call as erythroblastosis fetalis. So the baby is born with generalized edema. And other causes can be ABO incompatibility or minor cell incompatibility other than Rh negative. So we look at mainly the fetus having a fetal anemia because of hemolysis.
Hello. Yes, ma'am. Yeah. I think you have covered all the hemolytic disease of the fetus of the newborn, and we'll be going more in details with it with our fetal medicine experts on the team. There is also the typical syndrome known as maternal syndrome, which indicates that there is an imminent fetal death. And what is that syndrome? There's pleuritis for the mother, and there's proteinuria, generalized edema. So affected hemolytic fetus who's affected can also affect the mother because of the large size of the fetus and the complication related to the large baby because of the hydrops, preeclampsia, polyhydramnios, and so on. So moving to the third part of the question, this is for Dr. Umaram. Yes, madam, are you there? Yeah. You'll need to unmute yourself. You are on mute.
Yes, Vaishali.
Yeah, so we are perpetually worried about feto-maternal hemorrhage and the risk of isoimmunization. So which are the procedures which lead to increased risks of feto-maternal hemorrhage, and how should we reduce this fetal-maternal hemorrhage?
Yeah, so I think Shaijas had gone over this quite also in his lecture. You can group them into those events that can happen in pregnancy, which increase the risk of fetal-maternal hemorrhage. It could be a threatened miscarriage. It could be early pregnancy loss, either from an ectopic pregnancy or a molar pregnancy. It could be situations where there is an induced termination of pregnancy. So all of these pregnancy losses or terminations in early pregnancy, there can be fetal-maternal hemorrhage, though the amount of bleed is minor. And then you can have pregnancy loss or problems that can happen in late pregnancy, such as a late termination that happens because of an anomaly or an unexpected stillbirth or an intrauterine death. At whichever point in pregnancy it happens, we need to remember that fetal-maternal hemorrhage could have been a cause of that stillbirth, even if we don't have any direct evidence of it, and therefore we would need to cover that episode with anti-D. And any abdominal trauma or any obviously injury which can result in a fetal-maternal hemorrhage. Barring these situations, anytime we do an invasive procedure, which could be a chorionic villus sampling or amniocentesis or a fetal blood sampling, and obviously in today's age of fetal therapy, when we are putting in, we're doing laser ablations for twins, we are putting in shunts sometimes on babies. So those kind of procedures. And this I want to emphasize because it is very common today for women to come even for booking with already having had 2 or 3 scans, but without a blood group report. They may tell you their blood group is so and so or such and such, but there is no physical report of it. And many times as obstetricians, we don't take the care to actually ask for a documented report of their blood group. And therefore, I think it's very, very important. It may sound very fundamental, but especially in high-risk pregnancies, sometimes we see them without the serology documented, without the blood group documented. So the documentation of the blood group is very important. And these are the list of conditions. Obviously, post-delivery, we would need to give anti-D for these Rh negative women. As a practical tip, when they book and we tell them their blood group is Rh negative, it actually is a helpful practice to tell the woman that you would require this prophylaxis if you should present with bleeding. Because she may present with bleeding sometime in the night. There may be a junior registrar who at that point does not or somehow overlooks the blood group. And sometimes nowadays they call on the phone, second time spotting. We give them advice, especially in these COVID times when we are not necessarily seeing them. It's always useful to tell the woman, you trigger us. We have made a note. We know we have to give you, but you please trigger us so that this doesn't get missed. And I think that's a very practical value. And some of these risk factors, it's important to make a note in their record, so that irrespective of who primarily sees the woman, it doesn't get missed.
Yeah, Dr. Uma, so well said, and especially in these COVID times, it's important to sensitize the patient and create more awareness amongst us obstetricians also, and see to it that we reduce the incidence of fetal-maternal hemorrhage or detect it at the earliest and give the required prophylaxis. Now, talking about creating more awareness amongst our colleagues obstetricians, let us go towards more, case-based questions. These are some quick questions. This is for Dr. Manika Nandan. Is sir here?
Yes. Can you hear me?
Yes, we can hear you. So this is for you, sir. There is a primary gravida with 6 weeks pregnancy and she has had spontaneous abortion. So is there a need to give her anti-D? Can you just elaborate on this?
Okay, first of all, thank you all for inviting me. This question is a slightly tricky one because there is a conference answer and there's a practical answer. As Shaijas put it, fetal RBCs express antigens and in good amounts from about 6 weeks actually. and the risk of fetal-maternal hemorrhage significant enough to trigger an alloimmunization response is about 1 to 1.5% in early gestation. So the lady is at low risk, but not at nil risk. In my practice, I will give.
You will give. Anybody, any of the panelists want to differ with Dr. Manikandan?
If you go to the recommendation by the RCOG, they don't recommend if it is a spontaneous abortion, if you're not putting an instrument at 6 weeks of pregnancy. Before 12 weeks, they don't recommend. But I think, as Manikandan mentioned, as a practical point, it's better to give it because if she comes positive next time, then it's very difficult to manage.
So I think though you have quoted RCOG, but you yourself, Dr. Ajit, will give. And I think all the panelists agree that you will give. Dr. Ajit, like you quoted, RCOG has a recommendation is against, but there is a ACOG recommendation which says that with spontaneous abortion, the risk, yes, Dr. Parikshit, would you like, I will continue later on. Yeah, you go.
I think practically speaking, if it's a biochemical pregnancy, fine, you can let it go, But the moment you see a gestational sac or an ultrasound which documented that there was a pregnancy, I think it's safe practice to just give the anti-D because the effects are not reversible. I mean, they are permanent. The cost of the treatment is not that much. So why not give and be safe?
So the benefit is huge, and yes, you should give it, whether it is spontaneous or no. So RCOG recommends against it. There is ACOG strong recommendation for spontaneous up to 1.5%. There's the risk of isoimmunization, and of course, with the induced or surgical intervention, the risk of isoimmunization is as high as 4 to 5%. And also, there is documented reports that fetal RBCs are formed as early as within 38 days of implantation. So yes, we should be giving this patient anti-D, and I think all the panelists agree to this, and this is the message for all our viewers. So coming to Dr. Ajit, is he here? Has he?
Yeah.
Oh yes, of course. Yes, sir. This is for you. This is Gravida 2 Para 1 Living 1, 7 weeks ruptured ectopic pregnancy. Surgical intervention had to be done. And will you give this patient anti-D, and what will be the dose?
Again, ectopic pregnancy, whether it is medically managed or surgically managed, there is a significant potential for sensitization. So definitely we have to give anti-D, and the dose that is recommended is 50 microgram. But unfortunately, that dose is not available in India. So what we do is a practical approach is 150 microgram we give.
Right. So. Yeah, that's absolutely correct. And you spoke about medical management. Now coming to medical MTP. So I would like to ask all the panelists, medical MTP in OPD basis you're managing. So do you advise anti-D to these Rh negative women?
Yes.
Yes.
I think everybody is saying yes. So yes, it has to be given even for medical MTP. This is what many of our colleagues miss, they prescribe the MTP pills, but the anti-D at this point is many times missed. So this awareness needs to be created. What about vesicular mole? 7 weeks pregnancy with vesicular mole, does this patient require anti-D?
Again, Dr. Shai just told us vesicular mole we have to give. The problem with vesicular mole is that we cannot be 100% sure that it's a complete mole at the time of evacuation. So to wait for the histopathology report to come and to make sure that it's a complete mole, it takes time. So it's better again give anti-D. In partial mole, there is no doubt you have to give it.
Yeah.
In complete
give
mole,
anti-D. The message here is give anti-D. Coming back to you, Dr. Parikshit, this is a patient Gravida 3, Para 1, Abortion 1, Living 1 with 18 weeks pregnancy with incomplete abortion. She had to undergo surgical intervention. And then she needs to be given anti-D immunoglobulin. So what dose will you recommend?
Again, theoretically, we are supposed to give 50 micrograms. It's not available. It's either 150 or 300. So 150 is okay for this woman.
Right. Any of the panelists want to add to this or defer to this?
Agreed.
More than 12 weeks, I think I am for 300 microgram.
Yeah.
12 weeks.
Yeah. So again, here there are two thoughts. But after till 12 weeks, 150 micrograms suffices. But after 12 weeks of pregnancy, ideally it's better to give 300 microgram for a better coverage and a better prophylaxis. Suppose there is a patient with intrauterine fetal death, 18 weeks intrauterine fetal death, and you have done intervention, and after that you need to give anti-D prophylaxis. What will be the dose? Any of the
The
panelists?
important thing is that you give it at the time when the IUFD is detected.
Absolutely right.
Not when she delivers. The delivery may be after a few days, but give it as soon as you can. And then, post-delivery, you'll probably need to give it again.
Right. Absolutely right, Dr. Parikshit. As soon as it is diagnosed, it needs to be given, not wait for her to finish with the delivery as soon as it is diagnosed. So coming to Dr. Uma Ram, can you just tell us about antenatal prophylaxis? What is the routine antenatal dose? And though Dr. Saiju spoke about it, single dose or double dose, would you just tell us about it?
So actually, there is a fair amount of controversy around antenatal anti-D in terms of its routine use, especially in low and middle income countries. If you take the story in England and Europe, then clearly, as Shai just said, the numbers are there. If you gave postnatal anti-D alone, you have maybe a 1.8 to 2% chance of RH isomerization. The moment they introduced antenatal anti-D, then the prevalence dropped significantly from their 1.5 to 2% to something in the region of 0.7% or something like that. Unfortunately, in a country like India, routine postnatal anti-D itself is an issue. So how effective is antenatal anti-D going to be if you don't have postnatal anti-D is the question that we have to ask ourselves. So you can argue that you can invest your energy in ensuring postnatal anti-D cover happens everywhere, because that is the primary bar which can then be raised by adding antenatal anti-D. If we are going to use antenatal anti-D and miss postnatal anti-D, you are actually doing more harm than good. I think that is the clear message that all of us must take. We must have universal postnatal anti-D coverage to then ensure that antenatal anti-D enhances the coverage that is provided. If you look at the data on antenatal anti-D, single dose, again, you can be on either side of the Atlantic. That's true for many situations. You can have a single dose that is practiced in the US and 2 doses that is practiced. Actually speaking, there is very little head-to-head data on which is better. And if you then look at, so if you're going to give it, you can argue that you need to give the first dose at 28 weeks. Before you give it, you have to check the antibody titer. After you give it, don't check it and then say this woman is sensitized. So these are the things that we have to remember with antenatal anti-D. But if you look at the 2018 WHO statement, they actually say that in lower middle income countries, you should use antenatal anti-D only in a research context. And they look at cost efficacy, etc., to justify its value. Again, in India, we are a land of 2 extremes. If you're in the private setup and the woman and the people can pay for it, and they're going to get postnatal anti-D, it makes sense to give it, but we tend to give only 1 dose. But if you're looking at the public setup and you're looking at cost efficacy, it's probably greater value to invest in postnatal anti-D than antenatal anti-D.
Yeah.
Yeah,
So,
thank you.
Okay. I hope I just, just to clarify, because there's a lot of confusion about this. Yeah. And to add to it, our women read something and then they come and ask us, why are you not giving it twice? So sometimes for something so, there's a lot of discussion that ends up happening over this. So we have to have clarity in what we are saying.
Yeah.
To add up to Uma, what I want to say is, if you have a sticker made and put it onto the antenatal cards of the women, even if they don't come back to us, goes wherever, at least a postpartum anti-D. So we make a small green sticker. You just paste it onto them. So that even if they come in the midnight, if they have the file with the sticker, this woman is Rh negative.
Yeah.
We shouldn't miss on it. So some people may go back to their hometowns for delivery, at least now, if not antepartum, at least they don't miss postpartum.
I think
You're
on a lighter
absolutely right.
note, on a lighter note, they say, our food plate should look like rainbows with food of different colors for nutrition. Soon our antenatal cards will look like rainbows with one sticker for GDM, one sticker for anti-D. But I think it's important because, these colored flags, simple as they are, they catch people's attention. Like anybody will look at and say, oh, there's something there that we need to pay attention to.
So we are getting a lot of comments from our audience that this is an extremely interesting panel discussion. We are learning so much. 2-3 comments here. So congrats to all our panelists. And like Dr. Uma said, the take-home message here is yes, antenatal prophylaxis is very important at 28 weeks of pregnancy. And before you give this injection anti-D, 2 things you need to do, rather one important thing you need to do, that is do ICT. Do an ICT before you give an anti-D, because if the ICT is positive and patient is already ICU immunized, then there is no need to give anti-D. Then the entire management changes as an immunized pregnancy. But before every injection of prophylactic anti-D, ICT has to be done. Regarding 1 dose, 2 dose, there is no confusion. Both are equally fine. But for our Indian population, 1 dose is good enough. Like Dr. Uma pointed out, it is so difficult to catch them, and give that necessary dose. If you give 2 doses, 2 small doses, then you may give the first dose and the patient may miss on the second dose. So it is more practical to give single dose at 28 weeks of pregnancy. Dr. Tarakeshwari was talking about the same thing. So the next question I want to direct to you, ma'am. You'll need to unmute yourself. Can you guide us regarding post-delivery anti-D dose and what is recommended?
I think this was well presented by Dr. Saijas also. We test the blood group of the baby and within 72 hours we give 300 micrograms after the birth of the baby. That is the postpartum dosage which we give.
So blood of the, before you give post-delivery, 2 points important here is the blood group of the baby.
Yeah,
and
collect the
thing,
cord blood. Collect the cord blood.
Yes,
yeah, collect the cord blood for direct Coombs test and the blood group of the baby and give anti-D injection. 300 micrograms is the dose.
Absolutely. And sometimes if you lose the patient, then patient is not willing to give the benefit to the patient even as late as 8 to 10 days also is fine, but give it to her. Earlier the better, always better. No need to wait till 72 hours. Earlier the better, but please give it to her even if it's more than a week.
Yes, up to 28 days as was put in Dr. Saijas' lecture also. As soon as you remember, if you forget in your rounds, if somebody has forgotten that she's anti-D, she's Rh negative.
Yeah, that's the purpose of our webinar today, that our obstetricians don't forget such things and are more well informed. So coming to you, Dr. Ajit. Now this is a patient, Gravida 2, Paravan Living 1, 34 weeks of pregnancy. Her blood pressure is 160 by 100. She is diagnosed as abruptio. She has undergone emergency cesarean with a half liter of retroplacental clot which was retrieved. So in this case, we suspect that the fetal-maternal hemorrhage has been a lot. So my question to you is, how will you manage? What test will you do to assess the fetal-maternal hemorrhage? Sir, I do not want you to cover the obstetric part of the management, but what is pertaining to our topic today, Rh negative.
Yeah, the routine dose that is given in all patients, as Dr. Tarakeshwari told us, is 300 microgram. But here we can expect a higher fetal-maternal hemorrhage. So after giving that, we have to assess the fetal-maternal hemorrhage. We assess it. A simple test we can do is a keyhole bed test. And if the blood loss, if you think that the blood loss is more than 30 ml, 30 ml will be covered by your 300 microgram of anti-D, and then you have to give additional dose of anti-D. Then how we do this keyhole bed test is, again, all our labs may not do it, but you have to teach our lab people how to do it. What we do is make a simple peripheral film and do the acid dilution test. Usually, the fetal RBCs won't be eluted. The adult RBCs will be eluted. So they look like a ghost cells, and the fetal RBCs, you can see that cells. So find out the percentage of fetal RBCs in that film and use the multiplication factor of 50. That is based on the thing that the blood volume is around 5 liter, and then we get the blood loss, the fetal maternal hemorrhage. Say, for example, if the blood loss is fetal maternal hemorrhage is 50 ml, what we do is the routine 300 microgram will cover only 30 ml. So you have to cover the next 20 ml. So you have to give one more dose of anti-D.
Right. So apart from flower Bedke, would you like to advise any other tests for assessing
Other test that is available is the flow cytometry, but unfortunately, most of the places in India it is not available. So if you have flow cytometry, that is the best thing.
So flower Bedke is not really an outdated test. Like you said, it is immunoassay or flow cytometry is not readily available in all parts of our country. And flower Bedke test is an acid dilution test which is very easy to perform, like sir has told us now. And wherever you feel the feto-maternal hemorrhage is more, it is better to give extra dose of anti-D. In case you are unable to do this test and you are unable to assess the amount of feto-maternal hemorrhage, it is still essential to give the extra dose of anti-D immunoglobulin because it is going to benefit that lady. What is our panelist opinion regarding this? Yes, Parikshit.
So, the problem with the Clairol-Butke test is not that it's difficult to do or expensive. It's just that pathologists are not used to doing it because nobody asks for it. I did a simple exercise in the last couple of days. I phoned up 5-6 labs, where my patients usually go. And only one of them was aware that there's something like a Clairol-Butke test. So, I mean, if such a situation is there in a city like Mumbai, then I shudder to think what must be the situation elsewhere, because it's simply a question of awareness. I think it's nothing more than that. So, if there is such a clinical event where there is expectedly a huge amount of feto-maternal hemorrhage has occurred, and the clinician is struggling to get the KB test, then I think I would make a mistake on giving more anti-D rather than trying to be extremely theoretical, prove that there was a large FMH and then give.
The particular case, yes, Dr. Parikshit, so well said, that's so accurate. But the present scene case that we are discussing, where there is a huge feto-maternal hemorrhage has occurred, there is abrupt show, more than half a liter of retroplacental clot, and suppose the test is not available, then I think this patient definitely deserves more than the routine 300 microgram of anti-D. And there have been studies and recommendations which say that more the feto-maternal hemorrhage, you can go on increasing the dose of the anti-D immunoglobulin as high as to 1500 microgram. You can keep on increasing the dose by, and of course, if you need to give such a high dose, accurate estimation of the feto-maternal hemorrhage is very important. Yes, anybody wants to add to this? Saijus, you can also add to this.
1500 means 5 ampules, no? 5 ampules.
Yes, yeah. But before you give...
That is the maximum that we can give in 24 hours time. That is the maximum.
That is the maximum. Maximum dose you can give is still 1500. Yes, if it is indicated and if it is required. Talking about anti-D immunoglobulin, there's another interesting fact about where it should be given. Any of our panelists would like to answer that?
Yeah,
the site of administration.
Always it is
deltoid. Yes, always the deltoid.
As Shai just told us,
always the deltoid.
If it is an intravenous preparation, definitely we can go for intravenous. Otherwise, always deltoid.
Yeah. So when you give a big dose like 1500, then preferably better to give an intravenous dose rather than an intramuscular dose. So now coming to Dr. Umaram. This is a patient, again, this is a clinical case. This is a patient, gravida 3, para 1, abortion 1, living 1, 20 weeks of pregnancy, and her ICT titer is 1:32. So that means she is an isoimmunized pregnancy. This is a isoimmunized pregnancy. So what would be, how would you go about managing this patient? What is the role of the Doppler, MCA, PSV ratio, and how will you go about for fetal surveillance of this patient?
Yeah. So ideally, she would have, if she had booked with us earlier, we would have a baseline ICT because as everybody has said so far in the panel, that's something that we should do at booking. And in that kind of a situation, probably she would have had a, an ultrasound slightly earlier, closer to 18 weeks, to look at how the baby fetus is doing and also to look at the Dopplers. Now, if somebody does present to us at 20 weeks for the first time, RH negative, we have done a titer and the titer is 1:32. That titer is at what we would consider a critical titer, meaning that there is a good chance that this fetus is going to be affected. Irrespective, she needs an ultrasound because the titer only gives us an indication that there is isoimmunization and there's a possibility that the baby is going to be affected. We still don't know if this baby is RH positive or RH negative. And because we don't know her previous titers, whether it has risen or not is something that we don't know. In any case, 1:32 is a critical titer. I would send her for an ultrasound and an MCA Doppler because that gives us a direct correlation with fetal anemia, which is what we are trying to find out. And if the MCA PSV suggests, and you have said that, so we do an MCA PSV and look at the PSV mom. And if that PSV mom is greater than 1.5, then that's an indication that the fetus is anemic. And maybe when Manikandan speaks, he can tell us about how actually that mom value correlates for that period of gestation.
The
so
Mari chart and all that, if you can tell us about it.
Yeah, so this is a patient or this is a woman who needs to be managed alongside a fetal medicine specialist so that the decision on whether baby needs a transfusion, when the transfusion has to be done, how the follow-up has to be given, is something that has to be planned in conjunction with a fetal medicine specialist. So maybe I'll pass this question, part of this question on to Manikandan so that he can take us through how he evaluates the MCA PSV and how he decides on what the mom values are, etc.
Yeah. So, thank you, Dr. Uma and Dr. Manikandan. I want to ask, there are two questions for you. One is regarding what Dr. Uma has spoken about MCA PSV and how to arrive at the mom and what does mom more than 1.5 signify, and then how do we manage. So we make a Doppler based diagnosis that this fetus is affected. So how do you reach the decision of intrauterine transfusion? And sir, you are well known for doing intrauterine transfusions all over the country and all over the state. So we would like your expert opinion about this, about intrauterine transfusion also.
Okay, my approach and the protocol that I follow is based on what my teacher and mentor Dr. Suresh follows actually. So when we want to actually treat a baby with a fetus with anemia, it has to be a severely affected baby. So which means either we should have evidence of severe anemia or anemia with hydrops. So the first thing we do is we evaluate the baby for signs of hydrops in the routine B mode. And with this titer, I am talking about this particular patient. If there are no signs of hydrops, then we switch on the color and we study the MCA Doppler. The MCA Doppler, there is a waveform will be created. No? With the peak of that waveform corresponds to the peak systolic velocity. We measure that velocity. Now, the systolic velocity is contributed by the briskness of the cardiac stroke volume and also the viscosity of the blood. So when a baby is in anemia, severe anemia, and is in hyperdynamic circulation, this velocity will increase consistently in all anemia babies. We know that this velocity changes across gestation. So with every passing week of gestation, normally babies will be stronger heart, so they will have a higher velocity normally. So for the particular gestation, what is expected mean, we take that, and what is observed, that is the observed value that you measure in that particular fetus. So observed by expected median will give you the multiple of median. That is how we calculate multiple of median. Now, when the observed is 1.5 times more than the expected, then we say that the fetus is severely anemic. Instead of remembering what is the expected median across gestation, it's also easier to know a good rule of thumb. That is, if at 20 weeks, for example, this lady comes, I measure the MCA peak systolic velocity, and the MCA peak systolic velocity is 40 or more centimeter per second, then I can know for sure that it is more than 1.5 moms. So in this way, we can easily find out if the baby is severely anemic or not. Less severe anemia, we can monitor and not transfuse. We can wait till it is severely anemic, but also we should try and transfuse before the baby becomes hydropic.
So when you do IUT, we would you are routinely doing this procedure. So can you just tell us the procedure in short, what an obstetrician needs to know?
Yeah. Our policy is to do it as an outpatient with about 4 hours post-procedure observation, and it's for the mother, it's done under local anesthesia. The fetus will receive, after 24 weeks, will receive anesthesia and analgesia. There will be a combo of atracurium and fentanyl. So we immobilize the fetus, and we will find the best vascular access. It's always intravascular transfusion. The vascular access can be either the cord insertion at the placenta or the portal vein in the fetal liver. I and my teacher, we prefer the portal vein for a variety of reasons. We'll skip that reasons here. So we immobilize the fetus and put a needle into the portal vein and take blood, usually 1 to 2 ml of blood, and we assess the degree of anemia. And from that reading of hemoglobin in the baby, we'll be able to quickly calculate what amount of blood is required to correct the anemia. Now, the blood is usually kept at hand when this needle is passed actually, and we only have to calculate the volume. We generally use O negative blood, highly concentrated, that is double spinned blood. So the hematocrit should be around 70 to 75 and should be leukodepleted so that there are no viruses passing on to the baby, and irradiated. This is also important that we should irradiate the blood so that the graft versus host reaction does not happen, that the blood will not reject the baby. Okay, so after all this is done, we give transfusion through syringe, through a 3-way setup, and the whole thing takes about half an hour. The actual procedure takes about half an hour. After 24 weeks, we give nitroglycerin patch for tocolysis during the procedure, and before that we give indomethacin. I think after 4 hours of observation, we send the patient home.
Thank you so much. I think the way you have explained seems very easy, but we know this requires the highest of expertise. So for managing this patient, what you need is a team effort, complete team with the best of fetal medicine expert with us. Coming to Dr. Parikshit, so there is this isoimmunized patient. So is there any precautions you would like when you deliver this patient? And when will you decide to deliver? Is there any criteria by which you will take the decision that yes, this patient we need to deliver now?
So if the isoimmunized patient does not have any features of fetal anemia, then we are going to follow the standard obstetric recommendations. But by far and large, most Rh negative women should be delivered by about 38, 39 weeks. What are the things that we have to keep in mind? Let's understand that this woman is Rh negative. Blood may not be easily available, and it may be a good idea to organize blood, keep it cross-matched in the blood bank which is close by. If it's not in your institute, then somewhere where it is accessible. The decision of the route of delivery is really not going to get affected by the fact that she is isoimmunized. So standard obstetric practice there. It is recommended that these mothers should have continuous electronic fetal monitoring if they are in labor. After the delivery, do not prolong the interval between birth and cord clamping. And then, of course, collect the cord blood for serum bilirubin, direct Coombs test, and the baby's blood group. So those are the important things that we need to keep in mind.
Absolutely rightly said, Dr. Parikshit. And I just want to announce here we have crossed 700 plus audience. So congratulations to all the panelists. This is a very interactive, interesting discussion going on. Yes, Dr. Manikanandan wants to say something. You'll have to unmute yourself.
Dr. Parikshit mentioned how to handle the RH isoimmunized, but fetus not yet affected, isn't it? The part where we stopped now, let's consider the baby which has been transfused. That also requires little bit of an approach, a known approach. When we transfuse the babies, we transfuse at intervals of 3 or 4 weeks between transfusion, and we slightly manipulate the interval such that we give the last transfusion on the 34th or 35th week. So you have another 3 weeks. So the baby reaches term. It's very important, and I've seen my own friends and colleagues, they tend to deliver a little bit early just because we are transfused and the baby was anemic. I would say you should avoid that at all costs. A combination of prematurity and anemia is bad. So the fetal medicine unit will transfuse in such a way that at the last transfusion will be at 34 or 35. The time the delivery at 37 or 38. And what we routinely give here in my clinic at Pondicherry is that at about a planned, from the time we are planning an induction or section, depending on the case, 10 days before we start phenobarbital, 30 milligram, first initially BD and then TAD for enhancement of hepatic enzymes for the newborn. And this will reduce the requirements for phototherapy by about 75%.
Dr. Manikanandan, this is again for you. As a fetal medicine expert, what is the role today for spectrometric analysis and Lyell's chart, which we all have studied in our post-graduation days? Does it have any role today? Do you go and do amniocentesis and the spectrometric analysis?
No, I haven't seen one done, and believe me, my training was in the center which had the highest volume of IUTs. I haven't seen one. In the initial days when MCA Doppler was started to be used, when Mari published and all, people thought that once you transfuse a baby once, now subsequent surveillance may be hindered by the fact that we have transfused an adult RBC and therefore they won't fit the Mari's curve and predictions. But we have now strong evidence that if you have a combination of ultrasound monitoring and a calculation, because we know how fast the transfused blood is going to get destroyed in the baby, and the MCA Doppler, you will be able to manage without Lyell's curve. So at present, no role.
So the only role probably, as is mentioned in the books, is when if the patient presents late, more than 35 weeks of pregnancy, then probably there is some role at this point, because they could be sensitivity is less with the MCA, PCV, PSV mom. Is that so?
No, actually, I wouldn't. I wouldn't suggest anybody do an amnio at 35 weeks for diagnosing anemia.
Absolutely not practical. Yes.
what you
So it
can
is
do
out.
is
Lily's curve is totally out with the advent of
yeah.
Dr. Yeah. So that's the message here. And coming to our last question to Tarakeshwari, ma'am, this is for you. Can you just tell us quickly about now, like we said, we need a multidisciplinary approach to manage this patient. So this actually question is for a neonatologist, but your institute manages all patients, and you, I think, can answer this. The role of exchange transfusion in the affected newborn and post-exchange transfusion, what care would you like to do? Quickly, what are obstetricians would relevant to us?
I'm only aware that they do the cord TSB, and if it is more than 5 or a Paxil volume less than 30, they start an exchange transfusion. And or when they started milder with the phototherapy and not responding to phototherapy, and fetal anemia is much more than the bilirubin levels, then they start about this exchange transfusion. This is what I'm aware of. Post-exchange transfusion, they while doing it, they follow the bilirubin levels every 6 hours. And depending upon the response and other aspects of care of the newborn, and accordingly within 72 hours, they see the response. Nowadays, nobody goes up to that severe level of bilirubinemia of kernicterus, which we have only seen few mothers who come from districts whose baby was affected with kernicterus. Otherwise, it won't go up to that stage.
Yeah. Anybody has seen or has experience with exchange?
So, yeah, so if I can just add, so
Yes,
just as Tara has said, based on criteria, they decide whether it's an exchange transfusion or if it is just anemia that they are worried about, single volume transfusion. The point I want to make is that when the first IUT is done in the fetal medicine unit, when they draw the sample, they also document the baby's blood group. And that blood group has to be documented on the mother's chart. Because after delivery, because you have transfused this baby so much of O negative blood, the blood group that you will get is only O negative. And that's not the baby's blood group. And this gets dropped in many situations. That's why I'm making a point of this. Secondly, because we have transfused the baby so often, the baby's marrow is going to be suppressed. So we have to warn this couple antenatally that this baby is going to need followed neonatal care. Because many times couples feel they give it their best and everything because they think once the IUT is done and the baby is born, this problem is solved. But these babies do need continued neonatal care. They can be anemic for periods of time. They may need those single top-up transfusions going forward, sometimes for months, till their own marrow starts developing. And it's only at that point in time that the baby will have its own blood group. So this is information that needs to be communicated very clearly. And because many times what happens is these couples come from districts or from far away. They come to a tertiary center, they have the treatment, and then they go back. And then if they don't have enough information themselves, they end up having problems with this neonate after 3 months. And we've had babies that have come back all the way because nobody wanted to give them a simple transfusion because they found the blood group was different. Yeah. So that's also something that we need to pay attention to.
Yeah, correct. If I can add to that,
yes, please.
That's a very important point. Once you diagnose a severe anemia in the fetus, the counseling is that baby is now at high risk till about 6 months of life, postnatal life. You may bring it up to term, you can deliver, but the neonatal course is also going to be should be under supervision of a neonatologist who have experience in handling post-IUT babies. So I always tell them that up to 6 months, the baby will have to be monitored, and it takes about 6 months for the baby's own marrow to come in all cases. The majority will come in 1 or 2 months also. But it's very important that the neonatologist is taken into the loop, even in the antenatal period, and the mothers are given that holistic view. That's very important. Thank you, Dr. Uma, for bringing that.
Yeah, that's a very practical point. Another question I wanted to ask you, Dr. Manikanandan, in your experience of doing IUTs, they say if you do a successful IUT, the success rate is as high as 90 to 100% in a non-hydrops fetus, and as high as 80 to 90% in a hydrops fetus. So what is your personal experience?
Yes, RH anemia, or anemia for that matter, is a condition where we should never give up on the baby. Hydrops or otherwise, we should always think we can save the baby. In my own experience and in the experience during my training with Dr. Suresh, hydrops babies more than 90%. My thesis was RH and fetal transfusion. So our success rate there was close to 90 to 9, I think 91% for hydropic and 94% for non-hydropic. And if you do statistical analysis, it was never significantly different also. So in expert hands, it doesn't matter. Although we don't want the baby to go into hydrops, even if you see the baby in hydrops, don't give up. Don't give the option of TOP. The babies will always fight and come back. We just have to give them a chance.
That's a wonderful take-home message which you have given. Just don't give up on our babies on these pregnancies. We have finished all the questions of our panel discussion, but we do have a lot of questions here from our audience. So this is the first question. This is an interesting question by Dr. Vijaya Lakshmi Mantri. She's asked if we give anti-D at 36 weeks of pregnancy and the patient delivers within 1 month, is it necessary to give post-delivery anti-D?
Yes, I would say yes.
If it is within 2 weeks, 2 to 3 weeks time, it may not be necessary, but more than 3 weeks, definitely we have to give it.
So it is necessary. Answer here, Dr. Mantri, is yes, it is necessary.
Vaishali, if you don't mind, can I just make a follow-up comment on that?
Yes,
I
of
think
course.
if we are going to look at routine antenatal prophylaxis, if that becomes a routine practice, as it is in many urban centers, then each sensitizing event should also have the requisite anti-D administered along with your routine antenatal prophylaxis which you're giving, just to complete the spectrum of repeating anti-D doses.
So what Dr. Parikshit is emphasizing here is it is important to have your own protocol or to put in your protocol the required prophylactic and post-delivery regime of the anti-D. Here there is another question. Patient has received anti-D. She is now next pregnancy, subsequent pregnancy, she is ICT positive. So how will you differentiate whether it is due to the previous anti-D or it is ICT positive is due to this pregnancy? This is from Dr. Prema Kumari. Yes, any of the expert panelists.
Anti-D does not last beyond 12 weeks. So that's quite easy.
So there's the answer that once you give anti-D, it does not last for that long for the next subsequent pregnancy. And another question a lot of people ask is once you give ICT and then you once you give anti-D and do the ICT titer, the titer does not go more than 1:4. The titer is not very high. When a patient is isoimmunized, the titer keeps rising or goes above the critical titer of 1:32, or the critical titer may vary from center to center. But an anti-D given will never cause a very high rise in the titer.
Vaishali, 1 second. When you give an antenatal anti-D prophylaxis, as all the experts discussed, you would have done an ICT. And you're going to give it 28 weeks. At 28 weeks, your ICT was negative, you have given an anti-D. Don't check ICT after that. It will last till your delivery, and after delivery, based on the blood group, you decide whether to give or not. Don't keep checking it in between.
Yeah,
sometimes even the DCT will be positive at that time.
There's another interesting question. Many times there's a false positive ICT reported that it is positive. So how do you go about with the titer? What is the validity of the test? This is from Dr. Suman Mangala.
So if you have a positive ICT titer, then first of all, it should be in a reliable lab, a lab that you trust, that it will do a good job. Sometimes you need to ask them to do it in dilutions and you repeat it to ensure that it is persistent.
Yeah.
But as we have realized in the course of this whole webinar, ICT is only a guide. You're not going to anymore base management on the ICT titer. The management is going to be based on your ultrasound findings, fetal well-being, findings both on B mode and most importantly, your MCA PSV Doppler. So that is your decision-making factor. So once, if you have a doubt, then repeat the ICT, refer for an ultrasound, and the ultrasound will always be your deciding factor, not the ICT value.
Yeah, that's absolutely right.
Yes.
ICT, the deciding decisive factor is ultrasound. But talking about, she particularly wants to know about ICT. So you can do a quantitative assay of the ICT and of the levels and the antibody levels. There are some relevant levels like less than 4 milliequivalent per liter. It is not significant. 4 to 15 is what is significant, and more than 15 means this is a severely affected fetus. So this is what recommendations say about the antibody levels by immunoassay. Yes, Dr. Parikshit.
Okay. Sorry, sir. Please go ahead.
Please go ahead.
Okay. The thing about ICT and antibody anti-D titer is ICT is a fairly common, simple test. You will get it, and most labs are trained, most pathologists are well trained. Whereas antibody titer is a bit more tricky. If in that particular case, which Suman Mangala is asking, in your place, if you are not able to get a good ICT, it will be even more difficult to get a reliable anti-D titer. So better is to, okay, if you can get it, send it to another town or something, okay, but you can repeat it and correlate with ultrasound.
There's one more yes, Parikshit, you wanted to add something?
I just wanted to add another thing to this whole ICT testing thing. One, if we didn't discuss this in the clinical scenarios, I think that if there is a previous baby who has been affected, then please just don't do ICTs at all. They are of no value whatsoever. You have to monitor this fetus by ultrasound and color Doppler, and you know that this woman is already isoimmunized. So there's no point chasing titers and things like that. So I thought I'll just say that because that aspect wasn't covered.
Can I just
Previously
ask
affected fetus means the surveillance has to be very strict, because you expect this pregnancy also. The fetus may be likely to be affected, but at some point you will need to do an ICT if we are to give anti-D immunoprophylaxis to this patient.
No, why would you do that? See,
you don't need to give prophylaxis.
That immunization was in the last pregnancy, but this pregnancy you will need to know.
No.
She's iso-immunized. She's iso-immunized for all her pregnancies.
Yeah,
at the first visit, what the protocol recommendation says that every Rh negative pregnancy, in the first visit itself, we should be doing ICT.
Yeah, if there is a past history of, if there is a past history of alloimmunization, and we know for sure that it is an alloimmunized affected baby, then as Dr. Parikshit said, there is absolutely no role for ICT titer, nothing. 18 weeks onwards, MCA Doppler every 2 weeks till you find the baby is affected or the baby is delivered because the baby was an RS negative baby to a heterozygous father.
So the message here is very clear. The past history, of affection of the hemolytic fetus is very, very important, and no subsequent role of ICT. Is that right, Parikshit?
Yes.
Wonderful. Thank you for that.
Hopefully we can get NIPT and get the anti-D status at some point where we're using NIPT left, right and center for other things. If we can get...
and even the pre-fetal DNA testing for the fetus from the maternal serum, is it being done routinely in your place?
No,
because that will change the management completely of Rh negative pregnancy. The management entirely changes.
Not available.
Can I just ask a question, Vaishali madam?
Yeah, of course.
Something continuing with the ICT. the scenario that I was talking about, somebody receiving anti-D for recurrent episodes of bleeding. Okay, that means somebody had an episode of bleeding, and at that point of time, ICT was negative. You gave an anti-D. 3 weeks later, you want to know whether you need to give another dose. You do an ICT, and it turns out to be positive. As per the recommendations that come from the ACOG, they would say that if it remains positive, then you would say that the protection is still lasting in a body.
Yes.
Now, there's a question from Dr. Siddesh on whether that ICT positivity, whether it could have been because of the bleeding episode that happened and your anti-D not being able to cover it up well. Can somebody take?
Very unlikely.
Again,
Yeah,
Dr.
very,
Umar,
very unlikely.
it would be always less than 1 in 4. If you do it in titer, no?
Okay.
If it is the anti-D that is given, it will be always less than 1 in 4.
Okay. So
Also,
you can
Shaijas,
take that
that-
and
that-
differently.
And that scenario is very, very unlikely.
Okay.
Within 3 weeks, she getting alloimmunized and producing enough to, so that's very unlikely.
Fine.
I would say it's ICT, anti-D.
There's one more very interesting topic about delayed cord clamping. So is there any role of delayed cord clamping? Will you do it or will you not do it? Each one of you, if you can answer, give your opinion.
I think if we go by what we have been taught as postgraduates, we don't
do it.
Clamping. But we now have a generation of women, at least in the metros, who come and tell us that, or who are very keen that cord clamping is delayed, that they want to wait till cord pulsation stop. It's not uncommon. So I guess we just need to talk to them and tell them that there will be more antibodies being transmitted to the baby.
So Dr. Uma, you are saying no delayed cord clamping.
I
Anyone for delayed, you are against delayed cord clamping?
In
Anyone
RH
has
negative
difference of-
women, in RH
Yeah,
This is for RH
yeah.
negative. This
Yeah.
is entirely for RH negative.
yes.
Anybody has a difference of opinion?
No.
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 And
Okay.
most likely we have a partner in labor room now, one more person to monitor. When are you clamping the cord?
So let us see what the evidence says. There is this International Journal of Pediatrics, and there have been a lot of published studies which say, and even the NICE guideline, nowhere have they mentioned that the delayed cord clamping for RH negative, there is no mention against it. So yes, delayed cord clamping can be done for RH negative pregnancy also. Only thing is you should keep the cord length long in case this baby needs further intervention. But there is no contraindication as what was taught to us earlier and what we have been following, that no delayed cord clamping. But today the evidence shows that yes, you can do delayed cord clamping even for RH negative pregnancy, and it is going to benefit the baby, increase the hematocrit and hemoglobin level.
Again,
So
the
I
problem
think-
with the NICE guideline is that there are a lot of controversial points, especially they
So
don't
this is
agree with
the International Journal of Pediatrics evidence.
the NICE
and-
guideline. No, they contradict to the even the RCOG Green Top guideline, the British Society of the Hematologists. So all these things they
Yeah, so
contradict.
each
Yeah, so
recommendation
it's-
is contradicted. So I'm not quoting NICE, I'm quoting the Pediatric International Journal. So there's one more question. So take home message is here is yes, you can do delayed cord clamping and give the benefit to this baby also. Question here is follow-up of ICT positive sensitized patient till what gestational age? MCA Doppler should be done till what gestational age?
Yeah. It is also a follow-up to your question of whether we should do an amnio late in gestation. Generally, till about 35 weeks, the accuracy of MCA PSV is quite good. The false positive, that is, you overdiagnose, is less and it's about 10%. Now, after 35 weeks, it's not that you will miss a case, you can overdiagnose. And I think in a lady with ICT positive, it's okay to overdiagnose after 35 weeks. Let's say 36 weeks, your MCA shows a high velocity, you take it as severe anemia, you deliver. You're not going to lose much there.
Yeah. So one more interesting question, and I think this will be the last question because we are at this like more than almost 2 hours now. So this is the last question for our panelists. when the index pregnancy is iso-immunized, what precaution to be taken for next pregnancy and how to counsel the patient? This is from Dr. Sarayu.
Okay, good.
When the index pregnancy is already, it has
Yeah,
been
so
affected.
she's asking about the next pregnancy. Yeah.
That again, Dr. Manikandan mentioned about next pregnancy, the MCA Doppler starts from 18 weeks. But again, if she wants another option is, as Dr. Uma mentioned, you can go for a cell-free DNA by about 10 to 12 weeks. And another option even is if you want to have a RS negative baby for sure, even though it is an expensive thing, you have to go for IVF and even a peri-implantation genetic diagnosis, PGT. That is quite extreme.
Or simply an Rh negative donor sperm.
That is another option.
Dr. Parikshit, I was expecting this answer from you.
But I think that's a bit too much. I mean,
in a practical
that's not
sense,
realistic.
I think we need to, if they've had an alloimmunized pregnancy, they know what they went through. They know that the transfusions are going to be needed, but they also know that good outcomes are possible, assuming they've had a healthy pregnancy. So we just need to walk them through the things that we need to do for them. What is more challenging is if they've had an iso-immunized pregnancy and lost that baby. Whether after one transfusion or because sometimes they may have come with a very, very sick baby, and despite doing an IUT, sometimes the babies are so sick, they're already on so much cardiac load. Even when you give the transfusion, the fetus is not able to handle the volume of transfusion that you're giving. And you may have an IUD post a transfusion, or you may woman may go into preterm labor after the IUT is given and lose the baby to prematurity. So if they've had a bad outcome following an iso-immunized pregnancy, despite treatment, if that treatment has been initiated late, then it requires a lot of hand holding and telling them that you need to come early, you need to be started to screen early. So if we start doing early transfusions, the chances are the outcome will be better, but this is all that it takes. I mean, we'll walk the path with you, but it's going to be a path that requires a lot of hand-holding, multiple transfusions, intervention, and a team effort. So there is a fair amount of counseling, and this has to be done by a team which is experienced in handling this situation. And sometimes they will need additional support, both psychological, sometimes financial, to walk the path. So that's
I agree with Uma. It should be individualized. You can't have a take-home message for that.
Yeah,
you have to do all that.
Wonderfully expressed. And quickly, I would like each one of you. Yes, Dr.
On that, if the question was to know about the role of IVIG, then generally we don't use IVIG in a subsequent pregnancy following an affected pregnancy, but there are conflicting, let's say, contradicting evidences about its efficacy in delaying the need for the first transfusion. We don't use it because it's very expensive, and because that delay, if you refer to a proper fetal medicine center, is not that significant to make a difference in the outcome.
But they use IVIG for the neonates to defer transfusion. They use it in neonates to reduce the need for phototherapy and reduce the exchange transfusion rate. So it's not useful in the fetus, but it's useful for the neonate.
Yes.
Right. So just to wind up, take home messages from each one of our absolutely brilliant panelists. This has been really, it was a proud moment for me to interact with you all on this forum, and each one has just given wonderful messages. So can I have a quick round of take-home messages from each one of you, including Saijas?
You guys can
I'll
start.
I'll start. Don't forget giving anti-D. I think that's the take-home message. That's what happens most of the times.
Ajit sir?
The most important thing is the postpartum anti-D, and any sensitizing event in pregnancy, give anti-D.
Uma madam?
I think, I think those two are the key messages. But if you do find an iso-immunized pregnancy, refer early and refer to a center with experience so that there is a good take home baby.
Tara madam.
Don't lose hope. Individualize a mother and refer early.
Wonderful. Mani?
Yeah, don't give up on an anemic baby.
Fantastic. I have something to say actually. There are many days which makes me believe that, which makes me feel that I believe much more in my choices than I believe in myself. And whenever I say this, my wife readily agrees. I'm not talking about that today. I seriously believe that my choices of the panelists today, and of course the dynamic chairperson who came up with this, ensured that even in these days where webinar is becoming almost like a pandemic, we still had 700 plus people logging in to listen to you all. And a word about you all, I think the moderation was dynamic. You just, Dr. Vaishali, you took the flow so beautifully. You were with them. You countered them when it was required to bring out the best in them. It was a wonderful moderation. Uma madam, you were on fire today. I think those are few words that you spoke about how to bring in little bit more common sense whenever we practice evidence-based medicine. I think those need to be scripted in golden letters on probably the doors of every obstetrician's clinic in every part of India, I believe. Tara madam has been relatively a silent spectator, but because I know her, the fire with which she generally speaks, and I had the privilege of hosting her at Kannur, a phenomenal person, but a very, very keen listener, and she obviously added on whatever the other people had missed out. So it was those key add-on points from Tara madam. Parikshit sir and Ajit sir, they are relatively very benign looking people, but the most updated and the most gentle human beings that you'll ever come across. So the big hats off to you both. Dr. Manikandan, I know from my early days, has that knack of oversimplifying the most complicated procedures. Now, even if any obstetrician feels like going and doing an intrauterine transition today, I'm not surprised because he made it look so easy. So it's a big hats off to this wonderful gang. I seriously had the privilege of doing the collaborative work and arranging you all. And I seriously, it's a day in my life where I believe in my choices much more than I believe in myself.
Thank you, Saijus. Can I just say a few lines before we move on to vote of thanks? First of all, congratulations to you, Saijus, and you're truly dynamic. The way you have gathered the best of faculty, and they are indeed an expert. And Kannur society is a very vibrant society. Thank you, Parikshit. Thank you, Dr. Tara, Dr. Manikandan, Dr. Ajit. Thank you, Dr. Usha. And I have learned a lot on this panel from all of you experts. Thank you to Science Integra, TOG, and Bharat Siram. And it was indeed a great pleasure for me to interact with you all and achieve an achievement for Perinatology Committee, FOXI, to be with all of you. Thank you very much. Thank you to all the people who have logged in and are listening to us.
Thank you, everyone.
Yeah, thank you very much.
Before we wind up, there's an official vote of thanks from Dr. Simi, who's our dynamic secretary. And because I am stuck with a little bit of this election campaign work too, the good work that Kannur Society is continuing to do has been because of the groundwork that Simi is doing behind the scenes. But I really appreciate that, because without such a dynamic secretary, none of these things which Kannur Society is projecting today would not have been actually possible. So over to Simi for an official vote of thanks. Simi belongs to the team from Pariyaram with Ajit sir. The Government Medical College Kannur is what it's named as. Simi is the associate professor there and the secretary of the Kannur Society. Over to you, Simi.
Thank you, Shaijas. Good evening, everybody. It's my pleasant privilege to deliver the vote of thanks on this wonderful occasion. Management of RH negative pregnancy, it's always a dilemma, especially when the patients come with an ICT positive. But this particular webinar has given us a clear insight about this topic, and I am sure all the participants will be having the same opinion. First of all, on behalf of Kannur Orange Society, let me express my sincere gratitude and thanks to Dr. Ramani Devi, Vice President of FOXI, for being with us as a chief guest and for inaugurating today's session. Thank you, Madam. In the panel discussion, Management of RH negative pregnancy, Actually, it has taken us through a journey, starting from the pre-conceptional stage through the first and second, third trimester, and even after delivery, and also the next pregnancy. So it was and this panel discussion had given us so many clinical pearls, and especially the take-home message. The final take-home message was so wonderful. And the moderator, Dr. Vaishali, the chairperson of Perinatology Committee, Madam, you have done an awesome job. Thank you so much, Madam. And the expert panelists, Dr. Parikshit, Dr. Umaram, Dr. Tarakeshwari, Dr. Ajit, and Dr. Manigandan. All of you have done a wonderful job. Thank you all the panelists. Let me also thank the experts, Dr. Sumadi, Dr. Usha, Dr. Indira, Dr. Madhavi, and Dr. Kasturi for being us with as chairperson and also for your valuable inputs. And regarding Dr. Shaijas, our own dear president, and he has enriched with the updates regarding the anti-D immunoglobulin in the Rh negative pregnancy. Shaijas, it is an excellent presentation with so many take-home messages. Thank you, Shaijas. Let me also thank the office bearers of ICOG for supporting us and granting the ICOG credit points. We also thank the Pharma, Bharat Serum and Vaccines Limited for giving us all the support for arranging this webinar. Let me also thank the Science Production for giving us all the technical support. And a big thanks to all the participants who have logged in and made this webinar a wonderful session. Thank you all once again.